Good morning, everybody. We have a pleasure to present Dr. Stephen Nimer. He is the chair of the Sylvester University of Miami and the president of MDS Foundation now. Dr. Nimer, please, you can begin. Thank you very much for your.
Thank you very much, Fernando, and good morning, everyone. I'd like to thank Dr. Strebner and the GLAM for inviting me to participate and for inviting us, the MDS Foundation, to work together and to put on the sessions. I'm going to talk about epigenetic approaches to MDS, talk a little bit about the scientific basis for the treatments that we give, and talk a little bit about the future, what some of the research is leading to that may be new treatments that will come down the road. I have nothing to disclose. And, there have been several very large sequencing efforts to identify the mutations that are present in patients with MDS. And if you look at the most common, most of these involve epigenetic modifiers. Some are splicing factors, some are transcription factors. And among the most common, of course, TET2, ASXL1, DNMT3A. And if you look at some of the less common ones, they also regulate transcription, things like P300, CBP, GATA2, and PHF6. And so this suggests that MDS, like other hematologic malignancies, for instance, AML, may be driven by abnormalities in the epigenome, which result from the mutations that are seen within the genes. Now, the diagnosis of MDS has always been somewhat problematic, sometimes very obvious, but sometimes not. And so one looks at morphology still. We have lots of attempts to use AI to sort out the morphology of blood cells. And then we've depended on the presence of certain translocations or deletions, and then some of the molecular lesions, some of these mutations. And what we have found, in fact, is that the same mutations that I've mentioned, DNMT3A, TET2, ASXL1, are not only in MDS, but many of them are found in MPN. They may be found in CHIP. They may be found in clonal cytopenias of unknown significance, and even in other diseases, aplastic anemia and things. So the presence of these mutations by themselves do not allow one to diagnose MDS. They can be seen in other diseases. And so it continues to evolve using flow cytometry and other methods to get to the diagnosis. Of course, once one has a diagnosis, one needs to identify the prognosis. This shows the WHO classification, a publication now 10 years old, looking at the different prognosis depending on percent blasts and the amount of dysplasia that is seen. And everyone's familiar with the IPSS and then the revised IPSS, which looks at cytogenetics, bone marrow blasts, hemoglobin, platelets, and ANC, and one can then figure out the median survival. Now, what these things don't tell you is exactly how to treat the patients. And other than lenalidomide and 5q-, we use primarily clinical criteria for when we treat patients. One of the first studies to incorporate the mutations was published by Raf Bahar, who spoke yesterday, and he identified mutations looking specifically at a variety of genes, and he identified 5 genes in particular that all conferred a bad prognosis, shorter survival, and those include P53, EZH2, ETV6, RUNX1, ASXL1. These are all transcription factors or transcriptional regulators. And what he showed in this paper is that if you took the clinical criteria and if you had these mutations, it basically upgraded one. So low risk became INT1 in terms of survival, INT1 became INT2 became high. And so this incorporated a genetic profile for risk. Again, not really talking about the treatments that are available for the patients. And so if you look at the treatment options, I'm focusing in the blue on things that would be called epigenetic. And so we have the old standbys now, 5-azacitidine and decitabine. Lenalidomide is not a real epigenetic drug, nor is luspatercept. But we now have things like the decitabine, cedazuridine combinations. We have oral azacitidine. And what I'm going to talk about, also there have been histone deacetylase inhibitors, Prmt5 inhibitors, and acetyltransferase modulators that are entering into the clinic. So the most logical thing when you get these agents is to start combining them. There have been many, many studies combining drug A with drug B and drug B with drug C. And these are the different combinations that have been looked at. And as you know from clinical practice, none of these combinations are better than single agents. And so we're still trying to identify how to combine these drugs to get more efficacy. Of course, things like Venetoclax, when combined with these agents, works through different mechanisms and probably not through epigenetic mechanisms, but that's a very powerful combination in AML and increasingly explored in MDS patients. Now, these are the studies the original studies looking at azacitidine and decitabine that suggested a clinical benefit in terms of survival or event-free survival. And the first one, Lou Silverman's paper now is 19 years old. Okay, and this, the other publication from Kantarjian and others in cancer followed by about 6 years. And then, of course, the landmark study from Pierre Fenaux in Lancet Oncology, a study now about 12 years old, that showed that compared to sort of the best care, that 5-azacitidine had a significant survival advantage when used in MDS. And so based on this, you know, most patients get azacitidine, some get decitabine, and that has been the gold standard. And unfortunately, it's a little bit the old saying, to a man who has only a hammer, everything looks like a nail that needs to be pounded, is that so much of what we've looked at has been relative to people getting azacitidine. So these mutations that I talked about in general all predict for a better response to hypomethylating agent therapy. The mutations are shown here. The response rates, if you have the mutation, is here. If you don't have the mutation, it's there. And for the most part, having the mutation confers often not a great prognosis, but a better response to the hypomethylating agents. So along comes a couple of combinations. One is an oral drug. This came from the Wall Street article. First, we learned from Wall Street that the FDA approved in July of 2020 a combination of decitabine and cedazuridine, which is given orally. And then about a month or so later, the actual publication occurred from Guillermo Garcia Manero, where they did a phase 2 trial. And it was an interesting trial that led to the FDA approving, because they did a randomization. They had only 86 patients, 6 of whom never received the treatment, so a total of 80 patients. And at the beginning, they gave each of the drugs separately in separate pills, and then the last 34 patients received a single of the fixed combination. And so if you look at the data, first they showed that giving oral decitabine gave you the same area of the curve as giving intravenous decitabine, and that was very important to the FDA. The FDA was looking for equivalency. And then the second thing is that they looked at the responses, and you can see here there's 21% of these 80 patients had a complete response. A marrow CR was 22, and So 6 marrow CR with HI and some hematologic improvement. So an overall response rate of 60%, which led to the FDA approving this drug, which is slowly making its way into clinical practice in the United States. This is the survival curve. They gave the first cycle, some of the patients got IV decitabine, and the second cycle was oral. The others got first oral, then IV. And the ones that got the initial IV decitabine had what looks like a little bit better survival. But when you get out to about 2 years, the survival of all these seems to be about the same. So this is a new therapy that's available. And really the question is there any patient who would benefit from this as opposed to getting treated with a parenteral HMA? The second thing that's happened is oral azacitidine, CC486, was approved by the FDA in September, and it's based on a study published in the New England Journal. Because it's AML, I didn't show the actual data, but it's AML in first remission. The patients who got the oral azacitidine had a median overall survival of 24 months versus 14 months for placebo. And so, again, this is making its way into the armamentarium of AML therapy and is being extensively studied in MDS. One such study is being conducted by Chris Coggle and Guillermo Garcia Minero. There's an initial report in the Oncologist, and they treated patients. You can see here a very small number of first-line patients and second-line patients, and 11 of the 15 patients had a response as the initial therapy, but if you've been previously treated, about 35% of the patients had a hematologic response to oral azacitidine, and then they extended the dosing to continue, and they saw some continuation of responses using one of 2 different regimens. They didn't really decide which one was better, but 300 milligrams per day for 14 to 21 days. And this is not yet approved for MDS, only for AML in first remission. The other treatments that are available now, the IDH mutations actually work via epigenetic mechanisms. So the 2HG that's produced by the mutant IDH interferes with TET2 function. It also interferes with some histone demethylase activities and impairs differentiation. Now in the United States, both IDH1 and IDH2 inhibitors are approved for AML patients with those mutations and high-risk MDS. And what's been found in these patients is that they can get differentiation syndrome like ATRA in APL, and that the mutant cells differentiate in response to the inhibitor because you interfere with 2HG production. And so, and I'll just continue. Splicing factor mutations are seen not only in MDS, but in AML and in MPN. And Omar Abdel Wahab from Sloan Kettering made a mouse that mimicked the mutation. The mutation functioned differently than simply losing the SRSF2 gene. And so these mutations change the function of the splicing factors and create aberrant splicing. That what he showed is that if you have one mutant copy and one wild type copy in the mouse, you got a myeloid malignancy. But if you cross these mice, the mutant with the knockout, you didn't get mice. So if you have a mutation and you can get rid of the wild type function, the cells cannot survive. And so this led to a trial of an inhibitor of RNA splicing. And that inhibitor was from H3 Bioscience. They treated dozens of patients with this drug, and they had a 0 response rate. So that did not seem to be the right drug, may still be the right approach. And I mentioned earlier on that Prmt5 inhibitors are being tested by NCI-sponsored clinical trials. Prmt5 also affects the splicing of RNA. And so if you take cells that have a splicing factor mutation, they are very sensitive to Prmt5 inhibitors. And so this is an ongoing clinical trial looking at the effect of Prmt5 inhibitors on MDS patients. So in general, when one looks at what are the types of epigenetic drugs that are out there, there are bromodomain inhibitors, okay, so-called BRD4 inhibitors or bromodomain inhibitors. Many companies are working on that. You have the HAT or CAT, histone acetyltransferase inhibitors. We and others have shown that the nonsteroidals, sulindac, acetylsalicylic acid, some of these drugs can block histone acetyltransferase activity. The HDAC inhibitors are approved for treating lymphoma. Vorinostat, depsipeptide, and others, those have not been successful in MDS patients, in part because they cause significant fatigue. I mentioned PRMT5 inhibitors. They are now ongoing in clinical trials. PRMT stands for protein arginine methyltransferase. And there's lysine demethylase inhibitors. The most commonly targeted one is LSD1. And we and others have published papers using LSD1 inhibitors for AML and advanced MDS. They look more promising in MDS than in AML. And then there's a variety of lysine methyltransferase inhibitors like EZH2 that are being looked at. Chromodomain inhibitors have not yet entered the clinic. DNMT inhibitors obviously are azacitidine and decitabine. And IDH inhibitors are FDA approved as well. Now, in addition, there are efforts to eliminate the mutant proteins using things like PROTAC systems that degrade the proteins directly. And these and other things are being actively studied. There's about 60 different trials right now ongoing using different epigenetically targeted treatments. Sorry. Okay. I'm going to tell two quick stories. One, we all experience seeing low-risk MDS patients. And a year later, some of them have AML, or they have terrible disease, and others a year later have exactly the same disease that they had when they first saw you. And the question we asked, myself and Ken Figueroa at Sylvester, is can we predict in any way who's going to advance and who's not? So fundamentally, this is the setup we see, right? Many people have been studying how MDS transits to AML, but we're wondering, how do MDS patients get worse? Frequently, they don't show much difference in the bone marrow. They don't show much difference in the genetics, but somehow they're more anemic, they're more thrombocytopenic. And so this is the question that we wanted to understand. If you present to the doctor with MDS and some cytopenias, how can we predict who's going to be stable, and how can we predict who's going to have progressive MDS? So we took a few things. We took a baseline sample from around 20 patients, and then we collected serial samples for 18 months, okay? Every 3 months, we collected a sample from blood or bone marrow, and the group that had no change in the CBC for 18 months, that's stable. The ones who within 18 months had progressive cytopenias, had increased blasts but still less than 20%, or somehow had an increased transfusion requirement, were called progressive MDS. And then we took these follow-up samples. Okay, so first we learned the patients who had progressive MDS had a few more mutations. The ones who were stable tended to have 1 or 2 mutations, 0 to 2 mutations. The ones that had progressive disease tended to have 3 mutations. And so that was one bit that we understood. And then we looked for DNA methylation patterns. What we found was both using an unsupervised analysis that there was some significant overlap between stable baseline and progressive baseline. They were different than the normal peripheral blood. We identified the genes that were being affected by the change in methylation. And you could see here, these are the MDS patients who stayed stable and what their methylation looks like. And these are the progressive when we did the supervised analysis. Now, this is what normal looks like. And it just, you can see from the colors that the stable look a little bit more normal than does the progressive. And that's a baseline. So at baseline, we can figure out, well, it needs to be validated, of course, who's going to be stable and who's going to have progressive disease. We then looked at disease progression. And so the stable maintained a pretty stable phase. The progressives got much more different. So there was more drift. The distances between these two increased with time. There were more genes that were differentially methylated. And even in the unsupervised analysis and the follow-up study, even though these people are not excess blasts, you could see the difference now. And again, if you look at the normals, the stable stayed more normal. So we've been expanding these studies to try to identify maybe these people with progressive disease need to be treated at baseline before their disease progresses. And so we've shown that this is epigenetically heterogeneous. The mutational burden and the profile at baseline can correlate with clinical evolution, and we continue to advance this research. Now, I showed you earlier, that among the groups, there's also these mutations in CBP, also known as Krebs binding protein, and P300. And I wanted to talk a little bit about the research that we've been doing that looks at this. There's 3 families of histone acetyltransferases, the GNAT family, the P300 CBP, and the MIST family. And they've all been shown to have roles in hematopoiesis. So P300 plays a role in cell cycle, CBP plays a role in differentiation and DNA repair, and we've been studying these two proteins and how they affect MDS. There's actually a whole series of these proteins. They affect histones and non-histone proteins. They acetylate lysine residues on these proteins. And so the 2 that I mentioned, again, CBP and P300, they were initially knocked out in mice back around 15 years ago or so. And these are very complicated proteins. They're huge. They have a lot of different domains. They bind histones. They bind DNA. They bind to other proteins. And so they are similar to each other, but they are different. And so some time ago, we published a paper using a mouse model called the NUP98HOXD13 transgenic mouse, and we eliminated either P300 or CBP. So this is the normal mouse. This mouse dies either of AML or of MDS, just like the patients do. And in general, the mice live about a year and a half before something happens. If you eliminate P300, instead of the mice dying, half the mice dying about 10 months later, you find that all the mice are dead by 20 weeks. So you eliminate P300, and instead of the mice slowly dying from MDS and AML, they all die from AML. If you eliminate CBP, nothing happens. And this is shown down here. So this is the model. A third of the mice die of AML, a third of the mice die of MDS, and a third of the mice are alive. If you eliminate P300, 100% of the mice are dead from AML very quickly. And if you eliminate CBP, nothing happens. It's pretty much the same as just the NHD13 mouse alone. And so it's one of the rare cases where P300 and CBP function so differently, and that P300 is playing a role as a tumor suppressor gene. If you look at the stem cells in these mice, this is the normal. The LSK cell is the stem cell, about 3% are stem cells. If you look in the NHD13, there's almost no stem cells, which is very typical of MDS. And if you eliminate P300, you can see suddenly now that there's 20% stem cells, whereas normally there's 3%. So eliminating P300 increases stem cells. The stem cells go on to develop AML. And we believe that this is very important in human MDS because if this pathway is diminished, then the patients are going to get AML. None of these mouse died of progressive bone marrow failure. So P300 is determining what these mice will die from. If you look at the mice and try to grow the stem cells in the laboratory and replate, what happens is if you just inhibit P300 using a small molecule, you see a massive increase in serial replating, which is another stem cell feature. We also looked at the TET2 knockout mouse, and we saw the same thing. This is the TET2 knockout mouse. It develops CMML and slowly dies. If you eliminate P300, all these mice die of AML rather quickly. The white count is high. The mice are anemic. They have a low platelet count. And if you look at the bone marrow and the spleen, you find AML. The spleen of these mice is massively enlarged, and they get granulocytic sarcomas. And if you look at the stem cell pool, again, in this case, these mice have about 5% stem cells. The TET2 has about 7%, but if you eliminate P300 in the TET2, you get about 15%. The TET2 het has a normal number of stem cells, but if you eliminate P300, the stem cell numbers go up. And so you see the same thing in these mice. You eliminate P300 and you increase the stem cell number. Now, if you look at the TET2 plus minus mouse, those mice don't develop any disease at all unless you eliminate P300, and then those mice also get AML. So we've tested this in multiple models, the ASXL1 model and all these models. You eliminate P300, the stem cell numbers go up, self-renewal goes up, and the mice die rather quickly. And so here's the TET2 heterozygous mouse. You do serial replating of the stem cells and they exhaust like a normal stem cell would. But if you eliminate P300, these stem cells will grow indefinitely in culture, which is not normal. Okay, so it's great. We can take mice that are living and we can basically shorten their survival dramatically by getting rid of P300, but can we do anything to help them? Well, there's a molecule called ICBP112, which actually increases P300 activity instead of inhibits or diminishes it. And what we find is this drug, CBP112, can cause the stem cells to no longer self-renew. So you could see here that this very fourth column, there is no more self-renewal. So if you use this drug, you can eliminate the leukemic cell self-renewal. And that's shown again here with this drug ICBP112, where if you give this drug, you eliminate the colonies, you increase the acetylation, and you can block the leukemia. So we've been treating mice with this drug, MDS mice with this drug. We can prolong their survival, and we're working with drug companies to develop similar drugs that could be given to humans. Okay, to summarize this part is P300 and CBP play distinct functions in these MDS mouse models. P300 is a clear tumor suppressor gene, CBP is not. There are other contexts, other cancers where P300 is an oncogene, so you shouldn't think of these things as only an oncogene or only a tumor suppressor. And we continue to identify the unique vulnerabilities in splicing factor mutants, in TET2 mutants, in IDH mutants, so that we can find new combinations based on the alterations found in the cancer cell. And so my last slide, this is, hopefully you've all had a chance to visit Miami at some point. This is Christmas time. It was a cold day. It was about 60 degrees Fahrenheit. And this is my lab. We have great people at Sylvester who are working very hard. And I'll stop here. And I believe questions are at the end. But I thank you all for listening to my presentation.
Thank you, Dr. Nimer, for this interesting presentation. And we would invite Professor Pierre Fenaux, who is president of the Francophone group of myelodysplasias. Please, Professor Pierre.
Buenos días. Quiero otra vez agradecerlos.
I'd like to thank the GLAM and the MDS Foundation for inviting me. I will speak about high-risk MDS this time. As you know, the treatment includes the transplantation, which is still the only treatment with a curative potential, chemotherapy, which with new drugs is something that has to be considered. The hypomethylating agents, which is now association to HMA. For allogenic stem cell transplantation, I know that there will be a talk, but as I mentioned yesterday, now with patients who undergo transplantation with a haplodonor, the survival is almost identical or somehow lower than with a matched donor, matched sibling, but there's still a moderate difference, and this means that most of the patients now, almost all patients now, can have a donor. But there's transplantations associated to an important relapse rate. To the left, you can see that patients with a very complex karyotype and favorable karyotype of the revised IPSS and the TP53 mutation to the right, they have a very important relapse rate. So we need to do something to help them. And for the time being, we will activate a trial with an oral decitabine, ASTX727, and then infusions of lymphocytes from the donor. So we will start this trial hoping to reduce the relapse rate in those patients who have a high risk of relapsing. The important thing before a transplantation is whether finding if it's supposed to be performed immediately after reducing blasts with chemotherapy or HMAs. And it is considered that when there's more than 10% blasts in the blood, you have to reduce them. So these can happen with chemotherapy and also with hypomethylating agents. The HMAs alone generally won't allow to reduce the blasts immediately. So our following trial will be a comparison between CPX351. I will speak about this drug, the combination of AZA and Venetoclax, which reduce blasts immediately, but also there are some centers which still need to transplant patients without previous treatment. It won't be a randomized trial because it is very hard to randomize patients under these conditions and circumstances, because it depends on when the donor will be available. Chemotherapy, well, we'll know that chemotherapy is classic, 3+7, arrives to 50% of remission, but they are very short. They could be interesting before a transplantation, but otherwise it will be disappointing. Maybe the new thing here is CPX-351, which is liposome chemotherapy. And as we know, in secondary leukemias, it allows to obtain a better survival from the 3+7, which is classic, generally in patients who will then receive a transplantation. This is also valid for patients who have 20 to 30% of bone marrow blasts. We have implemented, well, actually, this is an intermediate analysis of a trial with CPX-351 in high-risk MDS. We have included 20 patients, and the results in the first patients is full remission in 15%, or incomplete remission 15%, medular revision 20%, and 10% failure. So all of these patients, 18 of them can obtain a significant reduction of blasts and then will be transplanted. And apart from this, we know that this drug has much less mucositis, which are associated to less mucositis of intensive chemotherapy. So it is particularly interesting in patients at certain age. Now, HMAs. We know that azacitidine in particular has shown an overall improvement if it's compared to conventional treatment, but this is actually very modest survival, if you will, with a median of 2 years. So actually, this is not enough. And apart from this, the response is somehow slow, meaning that the patients need 3, 4, and sometimes 6 cycles to get a response, which means that during several months, after 6 months, they are cytopenic, they have cytopenia for a long time. And this is a problem, and we know that it needs to be analyzed. Most of these answers are not full responses. It's 17% only, or partial response, 12% in this case. But they are hematological improvements of the cytopenias mostly. And 5 years after, survival is 4% approximately, which is now different from azacitidine and decitabine. So I think that we can say now that this is some degree of improvement, but very disappointing. We have to improve with new HMAs. Dr. Nimer has mentioned the oral azacitidine and decitabine and the 272, but azacitidine in oral azacitidine in intermediate and lower risk patients allowed to reach a 40%, 42% of erythroid response. It has not been compared with subcutaneous azacitidine, so it has not been used with high-risk patients. It's hard to say, really, if it can replace azacitidine, the classic azacitidine. Well, the potential advantage it has is that there's a duration of hypomethylation which is more durable and longer than with classic azacitidine. What we now know is that maintenance with oral azacitidine in AML with a first remission allows to increase the duration of full remission and survival rates compared to placebo. So now this drug has been approved under this situation. We really don't know if this situation, subcutaneous azacitidine, will achieve the same results. Another drug that we are analyzing is waracytibine in a trial compared with azacitidine and the cytabine did not show an improvement in the AML first-line survival rates. And ASTX 727, which is an oral decitabine with exactly the same pharmacokinetic profile, has been approved in the US, and the advantage is that it is an oral presentation. We have to improve the results obtained with high hypomethylating agents in combination with other drugs. There are different possibilities now. There are drugs which can be targeting to a pathway, the hashtag, and it might be, or it has a special target as IDH2 and 1. This has been presented by Dr. Nimer, TP53, and it can also, and finally, modify the immune system, particularly the checkpoint inhibitors. So first, there are clinical trials with HDAC inhibitors which have been negative compared to azacitidine alone. After this, a North American group compared azacitidine alone, azacitidine plus lenalidomide, plus vorinostat, and it was quite disappointing because the survival is exactly the same. We have carried out a trial with more or less valproic acid, lenalidomide, and azacitidine plus iradrubicin, and there were no differences in terms of response, just more toxicity with some of these combinations, and no difference at all in terms of survival. But now we have new drugs. First of all, we have Venetoclax, which is a BCL2 inhibitor, and we know that this HMA improves survival in the elderly. So I think that this is truly important. Initially, it increases myelosuppression, but since patients achieve a faster response, the total duration of myelosuppression is finally lower than with azacitidine alone, so there are no further complications. We just need to be careful during the first cycle, and sometimes they need to be hospitalized during the first full cycle. Now, this combination has been used in MDS, and this is a full remission of 40%, medular remission 40%. So most of the patients have a disappearance of excess blasts, which is very promising. And apart from this, the foreseen median survival will be 26. Now there's more follow-up, and we know that 26, 27, 28 months is probably more than with azacitidine alone. So this is actually a very interesting and promising combination also for MDS. Pevonedistat, which is an inhibitor and a clinical trial, has compared azacitidine, and azacitidine plus this drug has been authorized 2 years ago, has shown advantages in terms of disease-free survival to the left. The difference in terms of global or overall survival is not significant, but we know that these patients can receive other drugs in second line. So, first of all, it is interesting, and the disease-free survival in this case is actually an earlier parameter to assess survival than overall survival, and it is interesting in this combination. So we have started to use this in our trials. IDH1 and 2, just to say that the important thing is that we need to see that this mutation is detectable only at the time of relapse. So oftentimes, at the moment of diagnosis, when they start with azacitidine, there's no mutation, and after failure, the mutation emerges. So we analyze this every 6 months, more or less, with some patients. And we know the IDH2 results with a response rate at 50% of patients, something that might be durable in some of them. And now we have in the GFM trials with IDH1 and IDH2 inhibitors in MDS, which could be used after failing azacitidine or first line in high risk patients who don't have severe cytopenias. So it isn't necessary to start with the HMA agent. Or in low risk MDS with anemia that is resistant to EPO. And also we know that it can be combined, the IDH2 with hypomethylating agents, and this compared AZA plus enacitinib in AML. As you can see here, there is a very significant difference between disease-free survival, which is not translated into an overall survival. The median is 22 months in the overall survival, and with AZA alone, the overall survival is like 11 months. So we know that most of the patients from the AZA branch alone received enacitinib second line or were transplanted. This highlights the interest of having an evaluation parameter early on than overall survival. This means that they are very promising drugs as well. Now, what happens with patients with TP53 mutations? They are very, very complicated patients with complex karyotypes. Sometimes this is secondary to previous chemotherapy, and we have this APR246, which is an agent that works on mutated proteins, and we have implemented a phase 2 trial comparing AZA plus APR in patients with high-risk MDS or AML with less than 30% blasts. All of these patients have a very complex karyotype with, I would say, a life expectancy of 6 to 7 months as the median survival. We had the intention to treat with a 55% response rate, which is 65 because of those patients who truly were able to receive more than one course. And in MDS, 60% of full remission and the median survival of 12 months, which does not seem a lot, but if AZA is compared alone, maybe it would be worse. It's interesting, though, apart from AZA and apart from Venetoclax, because it does not make a myelosuppression worse. What about immunotherapies with DD1 inhibitors, PD1 and PDL1 inhibitors? For the time being, they have not shown improvements in the outcome obtained with hypomethylating agents alone. Maybe we are waiting some results from randomized trials still, but we could say that except for those patients with relapses after an allotransplantation, which is a very particular situation, it looks like it's not a breakthrough for the time being. Magrolimab is a CD47 inhibitor with a response rate that looks very interesting in combination with AZA, and especially a full response or complete response in around 40% of patients, and some other responses like adding venetoclax to the scheme and limited myelosuppression. And well, we still need to see what happens in the follow-up, but it looks very promising as well. Sabatolimab is a MSL1 inhibitor which is used for MDS and AML with response rates that look even better than with AZA alone. But with all of these drugs, there are trials which are comparing the HMA alone and the HMA plus the active drug in experiments. Sabatolimab does not make cytopenias worse, so it looks very promising. And there's Glasdegib, which is an ESMO inhibitor, which has been used with low dose, which low dosing showed promising outcomes with LDAC. So now we are expecting outcomes from all of these combinations, and so far any of them has been approved formally in or for MDS. What's the future of these HMA combinations? Well, the idea could be triple combination, especially for our cooperative groups. We know that the companies need to obtain the approval of their drugs in association with a hypomethylating agent against a hypomethylating agent alone. But as cooperating groups, we could therefore take a leap forward and anticipate to this maybe triple combination for AML. All of these combinations are AZA plus venetoclax plus another drug against AZA plus venetoclax alone. And there's AZA plus pevonidostat, which looks promising. So at the GFM, we have started to consider some triplets that could be AZA plus venetoclax plus an X drug or plus different combinations against AZA, Pivo, and venetoclax. What's key here, I think, in this combination is that there are two myelosuppressive like AZA and venetoclax, but the third drug could not be myelosuppressive if venetoclax is given in the elderly because they are treated at home. And we have to remember this. This is not compatible with a myelosuppression, which is severe. I would like to thank the Department of Hematology that I belong to in Paris and the group Francophone or the Francophone group of myelodysplasias, which is a group which activates clinical trials mostly. And as I said, we can have triplets or different combinations. We could, but we need to get the approval for those drugs. And we are not there yet. We work with a German group, with the Italian group, with a Spanish group, because in Europe it is easier to work in different countries at the same time. With European regulations, the trials might be activated in different countries. And we can try to work with other countries now. We have the ASA plus APL246, which has been activated in France, in the US, but this is the same trial. We are ready and open to any kind of cooperation. Well, thank you very much to you all. Thank you very much, Dr. Pierre Fenaux, for
Pathology, and she is president of La Junta Diretiva da Associação Colombiana de Hematologia e Oncologia. Dr. Virginia, bem-vinda.
Muchas gracias.
Thank you very much. It's an honor for me to share with you presenters of the quality that have preceded me. Today, we're going to talk about the allogenic stem cell transplantation. The idea, as we all know, this is a clonal evolution disorder. It has two spectra: the severe progressive cytopenia for transformation to a AML, although patients who have no risk of transformation have severe progressive cytopenias that affects their quality of life. The average age of 60 years at diagnosis makes patients that are frequently referred for transplantation. A study in the MD Anderson showed that 65% of patients who were eligible, only 33% underwent allo-HCT. There are many loss of patients along the way, and they start by ourselves who don't think in patients because of their age. Much of the information that we have available in MDS is retrospective. We need to consider and insist that the curative treatment strategy is transplantation. So for all diagnosed patients, our strategy should start from knowing if the patient is or not a candidate for transplantation, and the strategy should be focused in that sense. Of course, many patients will not have an indication. Transplantation is not for everyone, but those who have a transplantation may cure this disease. So how to disease who? Number one is to look at the patient's characteristics. The age has been considered as a first factor. We always want to think that for many years we didn't transplant older than 65. There's an increase in the limits for transplantation, and we see in this report of CIBA-MTR, patients over the age of 65 have more representation in the group of transplantation. And this is with the development of more optimal techniques that allow transplantation. And this study is very important because it shows us how age by itself is not a good predictor for outcomes. This is one single study, but this is seen in several studies with age as an independent factor. It's not prognostic in overall survival. On the other hand, the performance status measured with a geriatric standardized scale makes an independent prognostic factor that if you combine with the comorbidity scale is quite useful. This study has the advantage of being prospective of the few studies of transplantation in MDS. And as we can see, in patients less than 60 years of age, there is no significant difference in this combination. But for patients over the age of 60, the combination of these two indexes, if the patients have these two adequate, survival is going to be extremely good, over 50%, and the curve tends to flatten. But if the patient has impaired these two indexes, it will have a poor prognosis. So this is a factor that we can use to select what patients benefit from HCT or consider other strategy. This is when we look at comorbidities. This is a study that allows us to see how the comorbidity index predicts the incidence of mortality and relapse and overall survival. And if we combine it with age, you see the discrimination, the adequate discrimination of patients who want to have a poor survival and those who want to have a survival over 70 to 80%. So the combination of these indexes can help us in selecting patients. The evidence that we have available tells us currently that the prognostic factor is independent prognostic factor is a poor predictor of results, and all patients should be evaluated in a composite with comorbidity, age, functional scale will allow us to evaluate these patients who are going to benefit or not. There is a donor availability is very important. Several speakers have mentioned this before, but there's a lot of information, and what we know is we need to understand that transplantation and no transplantation, this is a large study, the curves only cross after the second year, but after the second year, where all the initial mortality following transplantation, the curve flattens. Those patients who don't get a transplant, the curve starts to fall. The patient who has a donor, and now we have to see what type of donor makes the difference in overall survival. With relation to disease-related factors, the blast in bone marrow, this has been repeated several times. The recommended number in most of the guidelines talk about 10%, but when you review carefully, it's actually 5% that makes the important difference, which is significant in a more consistent way in other studies. This doesn't mean that you shouldn't see patients with less than 10 or more than 10. What I want to mention here is that you should not stick in looking only to that magic 10% because their patients have 8% today, tomorrow they have 12%. And the idea is that if you don't enable to take them early, we will try to give treatments because we will make the prognosis worse. This clearly allows us to know that the IPSSR identifies a group of very high risk that are going to have a very poor prognosis with or without transplantation. And these patients, definitely, we need to quickly decide what to do with them and to think in the monoclonal. These are survival curves. And the other thing is that we were talking earlier about this and the molecular characteristics. 1,500 patients in the US with all the mutations that were found. The ASLX1 TP53 have a significant proportion of patients, has a significant impact for overall survival. Having P53 definitely, these patients need a different strategy. Of course, if you don't have a P53 and less than 40 years of age, look how these factors combine to define who and how this patient is going to go for transplantation. Molecular characteristics allow us the number of mutations and the type of mutations allowed us to predict what is going to be the outcome on the transplant. And if we're going to see myelosuppression, a patient with P53 positive should not go to transplantation or a large number of blasts. And we need to consider this for the risk of relapse. Cytopenias also are an important factor. Many patients don't have these risk factors but have significant cytopenias and behave as a bone aplasia. So this proposal of a predictor scale that is tailored, personalized to consider all the factors that we know in order to define the patient. See, well, your personalized risk for transplantation is this. This is what we expect is going to happen with your life, and make more informed decisions. And it's important in this case that the patient has more information. With regards of when, well, when it's like a balance game where we try to maximize the pre-transplantation time before exposing the patient to a high early mortality following the transplantation, but not delaying it so long so the outcomes will be adversely affected. This study is very important that showed us how patients, regardless of what we do, patients who underwent a BMT early in the course of the disease had a significant different outcome by taking patients earlier, to point out that we should think this early in the strategy when we want to transplant someone to be as soon as possible. The other thing to divide is a combination of the RIPSS that will allow us to define the life expectation without transplant. If the patient has a very good life expectancy, the patient can wait. And those patients in which we have a doubt, depending on the age, and I have an IPSS that's low risk, the expectation is not good despite that. So if you combine this with the CPMRT that includes age, peripheral blast, cytogenetic findings, performance status, and platelet count, allow us to estimate how the patient is going to go with a transplant and without transplant. And this is going to allow us, the combination of these two indexes will allow us to define who's a candidate and at what time we should take him or her for transplantation. The other key moment to think in transplantation is when there's a progression in the number of blasts, change in the risk group. So it's important to have a dynamic evaluation, look at the progression of the anemia, leading to a heavy transfusion burden, a lack of response to EPO, the acquisition of poor risk mutations, one mutational event that is acquired, we need to evaluate them again, and the failure of non-transplant strategies. The financial barriers and psychosocial barriers are important. We need to evaluate the mental status of the patient. The younger, more educated, well adapted, and less depressed have better outcomes. Financial burden for patients is quite significant, and the access also, which our patients in Latin America is a significant challenge, makes patients have uneven access to this treatment. And the patient's belief and preferences must be taken into account and take an informed consent. This is the therapeutic algorithm recommended for patients with low risk or very low risk factor. Should go to transplant as soon as there's a donor available. If there are no poor prognosis factors, we can proceed with non-transplant strategies. If they're failure, we can go for transplant. In patients who are not candidates because of poor performance status, will not go for transplantation. For high-risk patients, very high-risk patients, we need to evaluate. Age is not mentioned here, but the performance status, and if they have a donor or not, go for a non-transplant strategy, and if they have available donors, take them as soon as possible. If less than 10% blast, at least try the transplant or do some cytoreduction therapy. The result of multiple trials have been contradictory. The guidelines recommend treatment aimed to reduce the blast count at least 10%. with chemotherapy or antimethylant agents. With what we have, there's no significant difference. We need a lot of more information, but the important thing here is that we have into consideration the type of conditioning. And this is a patient who's going to have a non-myoablative allo-SCT. Those patients should be considered that they have less than 10% because the chance of response is also lower. So we need to balance treatment and toxicity, consider the relapse risk with higher blast, specifically if the transplant is going to proceed, and to consider the type of conditioning. If you consider a conditioning, the minimal residual disease has an important impact on survival. This is a study to show how patients of reduced intensity, and if they have residual disease by cytogenetic or cytometry, which are negative, that have the best prognosis. But with MRD, you can see their prognosis in this graph. While in treatment with the conventional intensity treatment, there's not much difference between a group and the other. Of course, patients who do better are those who have inactive minimal residual disease. The other thing to consider is the presence of new therapies. We already mentioned this. Hopefully, these new therapies, we can do more rapid response. With regards to the stem cell source, not only for MDS, but for all the transplantations, we know that the bone marrow is associated with a higher risk of relapse in high-risk patients. Peripheral blood has a higher risk. And graft versus host disease, at the end, there's no significant difference in overall survival in most of the study. There's some experiences that Fernando showed in a retrospective study, but many confusing factors. Peripheral blood is recommended as a source of high risk. Now, with regard as a type of donor, the Abello, in this study of 2014, specifically done in patients in the MD Anderson with MDS, a significant number of patients, 227. And if you see, the PFS had no difference with HAPLO or MRD or MUD. There's a greater difference in mortality related with transplantation in the non-related, but this is not significant. So today we don't talk, well, this comes from the same study. You see the forest plot and the type of donor, there's no significant difference. So nowadays we are talking about more than selecting haplo or non-related. It's the existing donor, but the best donor. There's no competition between HL and non-related. In the best donor that the patient has is a haploidentical young person. We can use haplo if that's the only thing we have considered: age, gender, CMV status, time to search an unrelated donor, because sometimes these patients don't have time. And as I mentioned, to select the best donor and not the type of donor. This is important to consider. This is a strategy that I like to use. The haplo indispensable strategy. With regards to conditioning regimen, there is a lot of information. Every time that you have to decide and reduce intensity or standard intensity, you need to think that with reduced intensity, you have a lower TRM. You're going to allow more patients be transplanted, especially older patients, but we're going to be paying the price with a higher relapse rate. Everything has a price. With standard intensity, we're going to have a lower relapse rates, and this is very important when we are taking a patient with NRD positive. We're talking about taking him upfront for transplantation. This is related that this is not a single factor that we need to consider, but it's a multidimensional evaluation. This is a comparison of a prospective study of BMT compared reduced intensity against conventional, and the PFS had no difference. Some significant difference in overall survival, and tell us this is not a single strategy you need to choose, but it depends on each patient. The decision to perform a allogeneic transplant must be taken into account a multidimensional evaluation. There's no ideal donor. Each patient should have a personalized evaluation. The curative strategy for MDS and should be considered for all patients earlier in all patients. And although there's no indication because of age, should at least do the exercise of considering them. There's not one size fits all strategy. This has to be individualized. There should be a risk assessment, very dynamic, that allow us to take the patient at the right moment to transplantation. This is what I had to tell you. Thank you so much for inviting me and have the privilege of sharing with you this presentation. Thank you, Eugenia, for your presentation. Ahora la doctora.
Is a hematologist and she works in the hospital of Salvador, and she is from Minister of Salud of Chile. Dr. Ximena, please, you can talk.
Buenos días.
Good morning. My name is Ximena Valladares. I'm an hematologist from the Hospital de Salvador in Santiago de Chile. And I'm going to show you a clinical case of a patient that was recently diagnosed in our hospital with a high-risk MDS. This is a 59-year-old patient, married, 7 children, with a history of type 2 diabetes, with a poor metabolic control, operated testicular cancer who received radiotherapy in the lumbar aortic area in 1986, and also a tuberculosis that required resection of the left lower lobe. Currently is taking metformin, no allergies, known allergies, no tobacco, alcohol, or drugs. This patient was admitted in January of this year because of a 1-year history of loss of functional capacity, dyspnea, weight loss, and chronic gingivitis. At the physical exam, the skin and mucosa were pale, no adenopathies or visceromegaly, and no skin lesions. In the blood count, we see macrocytic anemia with a hemoglobin of 8.2 and MCV of 113, white blood cells 1380, 300, and normal platelets. In this peripheral smear, we see the pseudopilia of the granulocytes, which are seen with no granules in fused segmentation of neutrophils. So now we're facing a patient who has a cytopenia with BCM high. The differential diagnosis should rule out a deficit of maturation factors, specifically vitamin B12, a history of drug consumption, chemotherapy or radiotherapy, as our patient has. Some autoimmune diseases could also present cytopenias as well as some viral infections. Hyperesplenism is a frequent cause of different degree of cytopenias. And once we rule out all these causes, we need to start thinking in bone marrow failure, where you have myelodysplasia, aplasia, myelofibrosis, nocturnal paroxystic hemoglobinuria, and any bone marrow infiltration for a hematologic or non-hematologic neoplasia. So following this algorithm, we studied our patient, had normal coagulation, biochemical normal profile with no ferropenic profile, but with a high ferritin of 907, and then the red test was negative, normal B12 level, rheumatologic serology that was negative, tumor markers were normal, protein electrophoresis and quantification immunoglobulins was normal, viral serology was non-reactive, and a CT of abdomen, thorax, and pelvis didn't show any adenopathies, masses, or visceromegaly. The myelogram, where we found a dysplastic in the red blood cells, megaloblast, a intercytoplasmatic bridge. Here we can see a typical nucleus in an erythroblast and then typical mitosis. And here we have the granular pseudopiliar hyposegmentation, binucleate erythroblast, and a megakaryocyte with a single nucleus that corresponds to a dysplastic megakaryocyte. This was reported as a trilineal dysplasia with 14% blast. Flow cytometry is the one we see here in this first plot. Cell scatter versus CD45. We have the dark green erythroblast, in light blue blast population, in purple lymphocytes, in light green the monocytes, in yellow we have eosinophils, and in red this corresponds to granulocyte. Granulocyte should be much higher, approximately at this level. However, because of the dysplasia, they're less complex because less granules and less segmentations, and therefore we see that this population decreases in size and complexity. Here we have the plot with a leucophorine. In green, we see the erythroblasts that correspond to 68%. We didn't find pro-erythroblasts because we rule out an erythroleukemia because of the large number of erythroblasts. And this is the population of blasts that in these two plots are seen that these have a myeloid lineage. We found 11% of blasts and 68% of erythroblasts, and it was diagnosed as a myelodysplastic syndrome with a blast excess and erythroid predominant. Cytogenetic, we found two clones, both with a 3-3 translocation. One clone had also a -Y, and the other clone a -7, plus an additional material over here. So, following WHO of 2016 for the diagnosis of patient falls in the classification of an SMD with EB type 2. Now we look at the risk stratification by IPSS. Cytogenetic had a 3-3 translocation at -7, which confers a cytogenetic group that's poor, and that provides 3 points. Has more than 10% of blast in bone marrow, so 3 more points. Hemoglobin less than 8 at diagnosis, 1.5 points. Normal platelets, and a ANC less, that's 0.5%. In total, we have 8 points, and this falls in the category of very high risk. So we have a excess of type 2 blast of a very high risk MDS. If you look here, patients of a very high risk has a very poor overall survival and a time to progression to AML that's quite short. With regards to treatment, this patient falls in the category of fit patients less than 70 years. So following this algorithm, we should think initially in taking this patient for transplantation. What we did is we offered the patient to the National Transplantation Commission, and we start azacitidine waiting for their answer. The patient tolerated treatment. However, after the third cycle, he persisted with this cytopenia that was quite similar to the presentation. At the beginning, in the myelogram, we saw an increase in the number of blasts, and we continue to see that this plastic change both in the red as well as in the megakaryocytic series. This was reported as a trilineal dysplasia with 18% blasts. In flow cytometry, we see that there's a higher number of monocytes, and among them 13% correspond to promonocytes. The number of blasts also increased from 11 to 15% at this moment, and there still are myeloid lineage plus, as we can see in this plot. We continue to observe these plastic changes associated to granulocytes. In this site scatter versus CD13, we should see a continuous red line as two parallel lines, a red and a light blue that correspond to plus. In the red lines, it continues because the granulocytes, as they mature, they acquire CD13. But what we see here instead is only the most mature ones at the end of the line. These other two plots show the sign of dysplasia in cytometry. In CD13, CD16, we see UV short morphology, and here we should have a U morphology. Here we see the N, which are the most mature, and all the rest is nothing, which translates into dysplasia. As a conclusion, this patient with 50% blast plus 13% of monocytes falls in the category of AML and was diagnosed as such. So there was a progression of the disease in the treatment with hypomethylating agent. Finally, our patient was accepted by the Commission for HCT, and he's currently in the induction 7+3. He's admitted in our hospital. He's in a period of aplasia, quite stable, and he started the study for the process for transplantation. Before concluding, I would like to invite you to the next GLAM Symposium in 2023, which will be carried out in Chile. You all kindly invited to this land of contrast, and we wait, hopefully, that we can talk and hug each other. Thank you very much.
For the all presenters, and now we are open for the discussion. And I would like to ask to Dr. Pierre Fenaux about your experience with Venetoclax and if you have infection or in patients with cytopenia in off kind of infection. Thank you.
Well, as I said during my presentation, it is true that the combination of venetoclax and azacitidine increases the myelosuppression as compared to azacitidine alone. But patients reach a response often earlier than with azacitidine alone. So the duration of myelosuppression is less eventually. To our surprise, I mean, initially we thought that it would be worse. Of course, a patient aged 85, I mean, because it's difficult, but for many patients, I mean, we tend to start with, for example, 2 weeks of venetoclax instead of 3 or 4 weeks. We add levofloxacin and posaconazole systematically to prevent infections. And well, I mean, we've been surprised, and our US colleagues who had more experience told us initially that there was eventually shorter myelosuppression. We hardly believed it initially, but it is true. Well, we have the largest experience in AML. Now in MDS, we are only starting, but there's no reason why it should be different in MDS, provided you are careful particularly in the first cycle, the two first cycles. And of course, you cannot apply that full dose to patients who are very, very old or frail.
Okay, thank you, Dr. Fenaux. We have the opportunity to use in 5 patients. Some of them are MDS and some of them are acute myeloid leukemia. And the most interesting thing is that exactly what you said, you have the same impression because only with one cycle, we have cleaning of the blasts. And we think about the possibility to go to transplant, it's a very good, very interesting kind of conduction of the patients. In your practice, do you use it anytime GCSF in these patients?
We don't actually. We never use GCSF with hypomethylating agents alone or with Venetoclax. I mean, well, perhaps we should. I know some colleagues do, but yeah, we don't.
Thank you very much. Doctor, we can open for the other questions from the audience and in the chat for everybody to.
Fernando, I have a question.
Please.
For Dr. Fenaux, do you think that it will be possible to choose the bridge to transplant based on mutation? For example, with the tools that are available now?
No creo que las dos, pues, para
Based on the minimally identifiable disease, maybe it's going to change our paradigm of treatment because we have the possibility of relapse, and we can maybe if you decide to make azacitidine with another drug, maybe we can change it. The history of this. I know that it's in the future. I don't know that it's not studies that can prove this hypothesis, but I think I think that we have to see a based, especially in the minimal residual disease, especially when you have the monitor about the flow cytometer and the next generation sequence. I think that we can think about this.
Totally agree, especially in patients with a high risk of relapse.
Yes. I would like to ask you, Dr. Stephen Nimer, about what you think of. We know that TET2 and the epigenetic mutations are very important in the MDS, in the genesis of MDS, but you know that the most of the treatments that we have now are not treatments specifically with this. You show in your great presentation the importance. What do you think that if you know more about this, we are going to improve our treatment in MDS? I don't know if Dr. Nimer is here, or is maybe no. Dr. Nimer, do you hear us? I think that he is Dr. Nimer. Do you hear me?
He had to. I think he had to sign off.
But I'm saying then okay. Then Dr. Virginia, you in your practice, do you have the experience of haploidentical transplantation?
No, yo en lo personal.
No, personally, I have not haploidentic transplantation in MDS. I have more experience with non-related. In general, the experience in the center I used to work, our experience in MDS, the patients that go better regardless of the type of donors are the patients who behave with that type of aplasia, who usually go well, but patients with MDS with high number of blasts do not go well. And unfortunately, in our countries, we cannot typify adequately that type of risk. And this is because we have a large group of patients in which we don't know what risk group they are. This is an issue that in Latin America, we definitely need to improve to treat our patients better. I have no experience in what you asked me. Thank you.
And the haploidentical for us in Brazil, specifically in the haploidentical transplantation, it's a very interesting a very option of treatment. And we have in our register of Latin American bone marrow transplant of patients with MDS, we have 31% of patients, 31 patients that did haploidentical transplantation. And in this preview analysis, as I showed in the last session, we have 70% in 2 years of response. Of course, we are going to look for the future of this, but I think it's a great option. It's like Dr. Fenaux showed. Thank you for your talk and and share your experience with us. You are muted, Dr. Fenaux. You are muted, please.
Creo que también
the haploidentical is an advantage because it's perhaps a 10% less survival, but it's easier to obtain, especially in current times where nobody can travel. It's easier to obtain an haplo donor than a non-related donor that has to travel.
End of our section, and I would like to say thank you for everybody for the brilliant and excellent presentations and the opportunity to stay with people so important and so interesting for our learning and for our experience. And thank you, Dr. Fenaux, for your cooperation and with Latin America. It's from long years. Virginia, Annalisa, Dr. Stephanie Nimer, and Ximena. Thank you very much for everybody. Be safe, and I'm very happy to stay with you in this morning. Bye bye.
Thank you very much. Muchísimas gracias. Hasta luego.
Bye bye. Bye bye.